Good evening, everybody. My name is Jean Wenjema. Welcome to tonight's Emergency Care Talk, the first of the year. I'm gonna hit it hard and fast. And the first talk is on hypertensive emergencies. Hypertension is like one of the most high blood pressure readings, one of the most common presentations to the hospital and the emergency department. And a lot of information out there is like, oh, high blood pressure is very dangerous. It's a silent killer. So when you have a high blood pressure reading, you're urged to come to the hospital as fast as possible, which is great because good health seeking behavior. So now it's up to you as a healthcare provider to know, is this scary? Should I worry about this? Or can I allow this patient to go home? Okay, so as we go through the talk, I'll be asking for you guys your contributions in the chat to see what you've been doing so that we can see where we're at, and then we can correct some practices and continue improving based on the evidence that's out there, because it's a continually evolving thing. Yeah, okay. So to start with, I will give you the dessert first. We're just going to talk about what hypertensive emergencies are and what they're not. We're going to talk about the different updates in terms of the literature out there, in terms of the approach to the patient, and the definitions that have changed, how to recognize what an emergency is versus what it isn't, how to manage it, and your disposition plan for your patients. Okay, so that's basically this image on the right is all that we're going to be talking about tonight. Okay, so I like to start with a case. Let me see if I can get my chart to what have we been doing versus what should we be doing, right? Okay, so first things first. Most patients are a bit older. So we have a 52-year-old male, known hypertensive, walks into the hospital complaining of a headache. He hasn't taken his medications for a month because after he took it, he felt better. And I think a lot of our patients say that, right? So vitals are done. He has a heart rate of 88, BP 182 over 109, rest rate 16, saturating at 96. So I'm sure we've all seen this kind of patient. So what do we do next for him? So one person says, repeat the blood pressure. Okay. So when we repeat the blood pressure, it's still 182 over 109. Comments. Repeat blood pressure, check pressure in both arms. Okay. Yep. So we repeat the blood pressure, both arms, 182, 109, 180, 110. Okay. Nelson says, assess for end organ damage through lab and imaging. James says, IV labetalol 10 milligrams. Target BP of 160/90. Take some injury, says take more history, check vital signs, assess for end organ damage, assess for signs and symptoms of end organ damage. Some say we have to lower the pressure and the patient has to take his medication constantly. Okay. Adalat chini ya ulimi. Okay. So yep, under the tongue, sublingual. That's nifedipine. And hydralazine. Yamdomo. Wow, interesting. Okay. Some people have seen give IV labetalol, take further history for end organ damage. Early Joyce says let the patient rest, inquire medications currently on, repeat BP after 15 minutes. Okay, okay. Interesting. So there's a lot. So sometimes enalapril and hydralazine work, and then also differentiate emergency from urgency. Okay, great. Thank you for your contributions. So we'll hold that case there. We'll come back to it, okay? So let's go to our definition of terms. So what we're all familiar with is hypertension is defined as elevated blood pressure, systolics of more than 140, diastolics more than 90. This used to be further classified in terms of class 1 to class 3 based on how high your readings are. So mild, moderate, then severely elevated. And then this also ideally was the approach into how you manage your patient based on this. So breaking news number 1, this has been updated and officially updated. So it's been an ongoing discussion, ongoing research, but the newest recommendations from the European Society of Cardiology and adopted by AHA, we're going to make it very, very simple for us, okay? So anybody who has a BP, office BP of less than 120/70 has non-elevated blood pressure, which is okay. They don't need any medications. You're like, cheers. You can go home, you're fine, okay? Then the ones who range between systolics of 120 to 139 and diastolics of 70 to 89 are deemed to just have elevated blood pressure, okay? So no class 1, class 2, class 3, no. So for these ones who are elevated, we want to know, do you have any cardiovascular risk factors that we can mitigate and possibly start you on medication, or you just need follow-up regular BP checks and lifestyle modification, okay? Then the third category are hypertensive. So just plainly hypertensive, where we have BPs of above 140/90, okay? So for these ones, the approach has changed. So usually that's your office or hospital reading. It needs to be confirmed. So you can do a subsequent reading in the hospital. Usually exactly the way you guys are saying, let the patient rest, and then repeat the BP after even up to an hour, up to 4 hours. If it's still elevated, then you know, yes, they actually have hypertension. Another reading that is very important is at-home readings. So again, we know the concepts of anxiety around hospitals and white coat hypertension. So we also want BP charting at home to see if there's any significant difference. And then based on all those summed together, some also get ambulatory blood pressure monitoring. I don't think we really do it much here. But those three, plus your risk stratification for cardiovascular disease, then you're started on medication. So that's the newest guidelines, that's the newest update in terms of hypertension alone. Then we go into now those ones who have very high BPs. So now when we're going to, in this little section on the bottom right, where it says exclude hypertensive emergency. So we want to know, these are the ones who walk into your office with systolics that are very high, diastolics that are very high, and you're worried about them, yeah? So this is basically going to be like the meat of our talk tonight. So hypertensive emergencies, okay? So there's hypertension, which is well and good. Many people have hypertension. Different areas in the country have different rates of hypertension. But what really matters for us as emergency care providers is if to know there's an emergency. And the only accurate definition of a hypertensive emergency is significantly elevated blood pressure, where you have systolics more than 180, diastolics more than 120. They can occur individually or together, but there has to be acute hypertension-mediated organ damage. What that means is it's not somebody who's had high BPs for like 5, 6, 7 months. No, it has to be an acute, abrupt rise in the blood pressure, and then that increased perfusion pressure causes damage in either the brain, the eyes, the heart, the lungs, the aorta, okay, through different mechanisms, but the most basic in terms of a pathophysiological level is your endothelial damage that can cascade into the worst case scenarios, like we said in all of these cases, okay? So that's what a hypertensive emergency is. One, it's a very high reading, above 180, 120. Two, it's acutely there. Three, there's end-organ damage that can only be attributed to the acute high blood pressure reading, okay? So those are the parameters when it comes to hypertensive emergencies, okay? So a singular high blood pressure reading in someone who doesn't have any signs or symptoms of end-organ damage does not mean that they have a hypertensive emergency, and means they don't need immediate blood pressure lowering mechanisms, okay? All right, so how do we know that there are end organ damage, signs of target organ or end organ damage. So like we said, brain. So one of the things you'd be looking out for is if there's a stroke, either ischemic or hemorrhagic, okay? Another thing is what we call hypertensive encephalopathy, where you have some form of agitation, confusion, convulsions that can't be attributed to anything other than the high blood pressure. Then in terms of the eyes, since they're very small vessels, the high pressure will cause, clinically, the patient or those around them will report visual disturbances. They can't see well, they're having blurry vision, they're having black spots, things like that, or complete sudden visual loss. So this would be hypertensive retinopathy, which manifests in terms of your examination in different forms, which we'll go into. If it's the chest, sudden onset chest pain associated with the acutely elevated blood pressure, or so chest and lung go together, acute cardiogenic pulmodema, so shortness of breath, they can't lie flat, they're just very anxious, breathing really fast, can't get enough air. Then you can also have, in terms of the large vessels, mainly the aorta, like in our image down there, you can have an aortic dissection. So that would present with sudden onset severe gripping chest pain radiating to the back, or back pain in an elderly patient requires, and high blood pressure requires evaluation of the aorta. Okay, then in terms of the kidney, we have an acute kidney injury. So if somebody had perfectly fine kidneys before, they'll have a sudden rise in their kidney function test, or the creatinine, the ureas, also the UACRs, things like that. If it's somebody who's known to have kidney issues, there will be an abnormal rise from their baseline, okay? So another thing that has been scrapped off, okay, is the notion of hypertensive urgency, okay? So the phrase of, oh, hypertensive urgency, hypertensive emergency is no longer there. We only have a binary prong or categorization. So hypertensive urgency, bye-bye, nice to know you. We've ghosted it, so let's all conform, because the notion is that, so first things first, there's a move to standardized care of hypertension and hypertensive emergencies across the world. And one of the ways to do that is to make it as simple as possible, right? And then even in terms of your management consideration, if you get a patient like our first case, BPs are high, you want to know, is this high BP causing damage that I need to immediately reverse? Or is it something that can be followed up in clinic with regular medications, lifestyle modification? So that's why it makes it very binary. It's either I need to give you intervention right now and lower it right now, immediately, or we can figure it out as we go along with constant medication, follow-up, and all that. So yeah, so we're just at the asymptomatic markedly elevated BP or hypertensive emergency. Okay, I hope that's clear. All right, so again, just to reiterate, I'm going to keep coming back to this image just to reinforce. So hypertensive emergencies, so acutely elevated BPs, systolics 180, diastolics 120, with acute hypertensive organ-mediated damage, okay? So basically, we have our brain, like we talked about the stroke, both hemorrhagic or ischemic, most commonly is ischemic. Then we have, so in our neurological, most common is usually, yeah, the stroke is the most common presentation of a hypertensive emergencies, getting up to about 38% from different literature. Always ischemic strokes are more common than hemorrhagic strokes. But aside from that, there's also hypertensive encephalopathy, okay? So in terms of the bleeds, you can have a subarachnoid, which more often than not results from a ruptured aneurysm, or you can have just an intracranial bleed. Most of the time, it's an intraparenchymal or intracerebral bleed. okay? So that's what we look out for. So how do we evaluate this when we think about a neurological hypertensive emergency? So these are the patients who come in markedly high BPs, above 180, 120. Maybe they're acutely confused. They were fine. Maybe they were like eating lunch or something. Then all of a sudden they dropped their spoon. Someone's trying to talk to them. They can't speak properly. They have arm deviation, speech either gone or slurred, and then weakness of one side. Or if it's depending on the territory, they can't walk. They have some gait ataxia. They're very dizzy, they're vomiting, things like that, would nudge you to think of a stroke. Another red flag is a very, very severe headache that reaches maximum intensity within the first few minutes. So that would lead you to think maybe a subarachnoid, okay? So that's in terms of your history. That would be the presentation. So in terms of your physical exam, you have to do your neurological exam. So there's the quick screening one, that's usually the FAST, F-A-S-T, face deviation, arm weakness, speech impediments, and then when the problem started in terms of time, okay? Because that impacts your management, okay? So hypertensive encephalopathy, not just sudden onset confusion, it can also be someone who has the sudden onset high BPs, then they're very lethargic, confused, or they have new onset seizures or are comatose. So that can be hypertensive encephalopathy. However, it's a diagnosis of exclusion, so you need to investigate to make sure it's not a trauma, it's not a ruptured aneurysm, all those things, using imaging so that you can say, okay, I've excluded A, B, C, D, E, so it is hypertensive encephalopathy. Okay. Yes, so in terms of evaluating these, imaging is your gold standard. So based on what you're looking for, CT scan versus MRI. So for your CT scans, mainly you're looking for your bleeds or your acute ischemic strokes, which would have a normal CT scan, especially in terms of if you're going to manage them with thrombolysis or something like that. MRI is better for your patients who come in with the transient ischemic attacks. So they've had weakness or slurred speech for a couple of minutes, then there's complete resolution. So you need your MRI, a normal MRI, to tell you definitively, yes, this is a TIA, okay? So all of those are within the neurological emergencies bracket, okay? So after the brain, we go to the eye. So like I said, the eye has very delicate vessels, very tiny vessels. So sudden high blood pressures cause very fast and rapid endothelial damage. And then also on the flip side, persistently or prolonged high blood pressure causes a continuum of effects on your retina, okay? So the retina is what we're mainly looking at. So if there is ruptured, if there are some ruptured vessels, you will have the hemorrhages, extensive, excuse me, extensive hemorrhages on fundoscopy. So yes, any person who has visual disturbances, you have to do a fundoscopy. I know it's not a skill that has been taught and reinforced in terms of our medical education, but it's a skill that you can also, we need to try and pick up and have a fundoscope somewhere ready, just in case someone comes at 4 a.m. and they say they can't see. You need to look before you call an ophthalmologist or SEO, ophthalmo, or whoever is in your facility who can do it. So some of the features, like we said, so it looked like a flamey retina where you have extensive hemorrhages, then areas of ischemic focus are cotton wool spots. You can have macular exudates, some whitening around the macula because of just the edema and the swelling. And then you'll have papilloedema, which is now, you look at your optic disc, your cup to disc ratio will be thrown out of whack, okay? So this is an emergency because if it is not attended to immediately, risk of permanent vision loss goes through the roof with every minute. And untreated, okay? So again, patient with sudden vision loss or a sudden field of their view becomes hazy or black, or they have black spots, that should lead you to think, okay, maybe we're having some hypertensive retinopathy, and then have a look, okay? Then we go to the chest. So I think this is the one that many people are very good at evaluating for. So clinical scenario, patient with high blood pressure, again, above 180 over 120. So there's a reason I keep drilling that in. 180, 120 is your number. So they come in with sudden onset chest pain, which you have to take very detailed history, because chest pain could be anything from acute coronary event to dissection to lung to skin to musculocutaneous, right? So characteristic chest pain, so feeling like pressure or something sitting on the chest, radiating. So funny enough, studies are radiating to the right arm is more sensitive and specific for acute coronary than the left, followed by bilateral, then now left is after that. So trying to find out what does the pain feel like? When did it start? Is it worse with exertion? Are you having shortness of breath? Things like that, okay? So with the shortness of breath, cough, difficulty breathing, unable to lie down, you're thinking about acute cardiogenic pulmodema, which just means that, okay, we're going into a bit of heart failure. We need to curtail these blood pressures and get them under control as fast as possible, okay? So those are some of the cardiac emergencies. But with cardiac, we also come to our vascular emergencies. The most important organ that we look at is our aorta. So it's the largest vessel. So very high pressures can cause a rip between your different arterial layers, the intima, the tunica intima and media. So with each compression of the heart, and that being at very high pressure, causes that dissection to continue expanding, and you can have a dissection from the base of the aorta all the way down to your renal arteries, which we do not want, because that compromises circulation, blood flow, oxygenation of all the other organs, and then you get a false lumen, and it's just bad, very, very bad news, and very difficult to manage. So the sooner you identify it and get your blood pressure under control, the better, and the higher your patient has a chance to survive, although the mortality rate is quite high. So in terms of patient complaints, it'll be a very severe, like ripping chest pain. Patients say that they feel like their chest is being ripped apart. It radiates to the back often. Sometimes you might even have, especially in the older population, they might just have back pain. It might be an older man who says he has some severe back pain. And then what's also very characteristic of aortic dissections is, despite the amount of analgesia you throw at them, you'll throw the paracetamol, the diclofenac, the tramadol, the morphines, the pethidines, all those, you'll throw all of them at them, but the patient will still be wreathing in severe pain. So that also is a red flag that should prompt you to have a look at this, okay? Yeah, so diagnosis is obviously definitive diagnosis is a CT aortogram, because you want to see the contrast going, and then the false lumen and all that. Yeah, ultrasound is not very specific for this. So yeah, CT aortogram is your gold standard. Then in terms of the kidneys, so like I had said earlier, it can be two things. It can be a new onset acute kidney injury, or a worsening of an already altered baseline, okay? So these are the patients who will come in saying, they're feeling, well, they haven't passed urine maybe a couple of days or like once a day. And even that little urine, maybe it's very, very concentrated, very little amounts. Sometimes even despite oral intake. Another thing that will be there is signs of overload, fluid overload state. So they'll have like peripheral edema, they might even have pulmonary edema. So those are some of the things you look for in terms of your history and your physical exam. And then you need to trend your kidney function tests, plasma urine, urinalysis, check for your proteins, things like that will let you know. Okay. And then also in terms of if your patient can't give you a history when you catheterize them, no urine output, especially if they have a protracted stay in your emergency department. Okay, so all those organs are in terms of primary or essential hypertension. However, you can have a hypertensive emergency in terms of your secondary hypertension. So secondary hypertensions are the ones that are due to an organ failure. So it's like a reverse or a rebound hypertension. Okay, so some of the classes that we talk about here, so we have our preeclampsia, eclampsia complex. So very high blood pressures. I think the latest guidelines above 140/90 should raise a red flag, and then repeated blood pressures of that. That's number one. Number two, one reading of above 160 systolics is a red flag, or features of severity like your palmedema, things like that. And then in terms also your labs. So preeclampsia, eclampsia is also something that when the BPs are really high, you want to, aside from managing for convulsions, you also want to lower your blood pressures below 160/90. Okay. Another thing, pheochromocytoma. So adrenal glands going haywire can cause your BPs to go really, really high. And then this can be, so it wouldn't be the only thing. You'll have other things like palpitations, very high tachycardias, diaphoresis, agitation, all that. But if you're in the background of all of this and you're suspecting it's from a pheochromocytoma, you want to lower your blood pressures with specific agents, considering the background pathology. Another thing that can cause a hypertensive emergency is cocaine abuse, mainly in terms of overuse, abuse, overdose, that's the word, yeah. So again, depending on these ones, you have to really consider this pathology in terms of how you manage and your target, how you manage with which drugs, and then your target blood pressures. Okay. All right. So like we said, hypertensive emergencies, acute high BPs over 180, 120 with acute hypertension mediated organ damage. Okay. So in terms of your history, like we went through, you have to ask all these questions. So that you can screen in terms of your history, you have to examine, see what's happening. And then now we can go to your additional tests. Okay. So we had said some of the tests that we want to do. For if you're thinking it's the head, you want neuroimaging as appropriate, whether it's a CT scan or an MRI, but preliminary CT has to be there. Your eyes, you want to do your fundoscopy. Your chest, you must do your ECG. You must do your ECG. And you need to know what you're looking for, okay? So it's not just ST elevations that can be suggestive of an acute coronary event. So it's the whole sequence of STEMI and STEMI, and even features of heart failure, right heart strain, where you have your BBBs, things like that on your ECG are very, very important to look at. Then in terms of your aortic dissections, you want your CT aortogram. Some depend, again, ultrasound is not the best, but you can have an echo to tell you, one, it'll tell you about any features of heart failure, your systolic or diastolic dysfunctions, things like that. Mainly, that's the most accurate thing that you will want to look at, especially if you're having cardiogenic pulmedema. You can also, even with your podcast, you can look at your lungs and see how they're looking. Is there features of a tamponade, things like that? You want to do that with your ultrasound. It's not the best at looking at dissections. I know some people say you can see a double lumen, but again, that ultrasound is very user dependent. Okay, so if you're thinking dissection, aortogram, CT aortogram is your safest bet. Then you want your kidney function tests plus your urinalysis to see what's happening. And then if it's a woman of childbearing age, a quick urine PDT, and then also abdominal exam to see if there's a fundal height above 20 weeks, right? And if they're seizing, so those are the ones that will tell you. Then in terms of like drug history, if they can provide it themselves or circumstances around them coming to hospital are suggestive, then you can't ignore that, okay? So, okay. Now, when your patient comes in, we're going to talk about now management, right? When they come in, you do your vitals, you note that they have high blood pressures, right? So then now you go ahead, you take your history, you do your physical exam, you do your ECG, also do a sugar, because one, if your patient goes down the algorithm and they end up not having an emergency, but they still need care, right? And part of their care includes risk stratification, and things like diabetes are considered in that. Okay, so yeah, investigate, fundoscopy, labs, and then imaging as appropriate. Head, CT, MRI, chest, X-ray, CT, ultrasound, eyes, fundoscopy, kidneys, mainly labs, but later on you can do your ultrasounds and stuff, but mainly labs. And then heart, ECG, and then labs like troponins and stuff, and then echoes or bedside focus. Yeah. Okay. So those are the major emergencies that we'll be looking at. Okay. So if any of those organs elicit a flag in terms of you've confirmed that there is an emergency, you've seen there's a bleed in the brain, you've seen that there's definitely a stroke, or your kidney function is bad, they have pulmedema or auscultation even, you want to intervene immediately. So there's definitely an emergency, and emergencies are dealt immediately, okay? So all these patients, our ABCDs still apply, okay? When we're resuscitating, we resuscitate systematically so that we don't miss anything, right? You don't want to be giving an IV antihypertensive and your patient can't maintain their airway because you'll just be doing zero work, okay? So your ABCDs still apply. And then even if you needed to intubate your patient, your choice of drugs needs to be cognizant of the fact that you already have these certain problems. So you need to choose your, especially your sedation drugs appropriately based on what the pathology is that you're thinking the patient has, okay? You don't want drugs like ketamine, which inadvertently raise your BP and you're already on the higher end, okay? So in emergencies, we only use IV medications, okay? If you're going to give someone an oral medication, it's not an emergency, or you're not treating it correctly as the emergency it is. So ideally, there's really no room for oral medications in an emergency department. Outpatient, sure, why not? But since they're going home, they can pick up the drugs at pharmacy. But if there is signs of acute hypertensive mediated organ damage, get your cannula in, start your IVs as appropriate. And medication choice depends on multiple factors. in our setting, availability is a big thing to consider, because if you only have hydralazine, if you only have labetalol, you don't have other things, it's better you give that than nothing, okay? So based on availability, number one. Number two, what pathology does the patient have, or which organ is affected? And then is it primary, secondary? So those are very, very important. And then is your patient pregnant or not? So those are important to consider. Okay, so directly from our algorithms that I think we're all familiar with, on the Casualty app, you can just key in hypertensive emergencies algorithm. So you want to, like we've been talking about, does your patient have a concerning BP, which should be above 180, 120? Okay, and the history surrounding that. You want to monitor and support your ABCs, like we said. If they need to be intubated, intubate first. You must do your RBS, because you could have even confounding elevated sugars, and then also in terms of your risk stratification later. If they need oxygen, give them oxygen. Target is usually 94 and above. Then you want to get your samples, like we were saying, all the samples, including a pregnancy test, if you think your patient could be having preeclampsia or eclampsia, okay? ECG is very, very important, especially for your acute coronary events or acute cardiogenic emergencies, okay? Then, like we said, your history is important. It will direct you to look where the problem could be, but you shouldn't overlook the other places that could have issues, right? So even if you're thinking a patient has an acute kidney injury, still do your ECG. Still, if they're childbearing age, still do your PDT. You never know, okay? So we want to figure out, so if from our history, physical exam, and our investigations, we've pinpointed that it is a neurological emergency. So if it's an ischemic stroke, depending on what you intend to do, so how long have the symptoms been there, right? The less than 4 hours, we want to consider thrombolysis, right? But you can't thrombolyze with very high BPs. So you'd want to lower your blood pressures within the first hour and then thrombolyze, okay? If it's outside the thrombolysis window, you have a bit more time to lower your blood pressures, even up to 24 hours, okay? Then if it's a bleed, okay, you do need to lower your blood pressures, and then depending on which kind of a bleed it is, if it's a subarachnoid, you want to lower it quite fast. So your BPs need to be less than, systolics less than 160. And then there are other drugs that you need to add to prevent added complications of the subarachnoid. If it's an intracerebral bleed, you do need to lower your BPs fast, but not too fast, because you don't want to risk hypoperfusion at the same time, okay? Then cardiac events, like we said, your MIs, your palmidemas. So you want to see what does my patient have, because that also dictates the medication that we're using. So if it's just an MI, you want your labetalol, and then you can use nitroglycerin depending on which vessel is occluded, okay? And then also plus your BPs. Again, if it's too high and you're thinking of thrombolizing or anything, you want to lower it a bit before you do anything else, okay? If it's palmedema, you're thinking you can use some nitroglycerin, or if you have nitroprusside plus a loop diuretic like furosemide would be good for these patients, because you want to, aside from just lower the BPs, you also want to reduce their overload state, okay? So those are some of the ones. I will talk about this again in the next slide, but just as a brief overview, and knowing that this is also in your algorithms, including the target blood pressures for each and how fast and which drugs to use. Okay, so again, so if it's cardiogenic in origin, so if it's an ACS, acute coronary symptom, you're thinking an MI, you want to immediately lower your BPs. Your target systolic is less than 140 millimeters of mercury, because you remember, as you're in your contraction phase, that's when your coronaries are being perfused, right? If that's too high and there's already a blockage, that causes more damage, okay? So you want to immediately lower your BPs. Target systolic is less than 140. Like we said, drugs to use, labetalol, nitroglycerin are good. Nitroglycerin has some caveats. So depending on where you think your MI is, okay? If it's a posterior one, or an inferior and RCA one, you don't want to use that because it'll knock out all your preload, inter-preload dependent. Yeah, but the other ones are safe. So that's important to remember. If you only have labetalol, give the labetalol, okay? All right. Then for your acute cardiogenic palmedema, like we said, we want to not only lower the blood pressure, but also get rid of the fluid. So the drugs are pretty much the same, nitroglycerin or nitroprusside if available, and then a loop diuretic. So luckily for these two, your acute coronary syndrome or your acute cardiogenic palmedema, your target BPs are the same of less than 140, and your drugs are pretty much the same. Only for the palmedema you need to remove the fluid. Okay. Now for your for your aortic dissections or aortic disease, AS is acute aortic syndrome. Like we said, any further pressure in the aorta causes a further rip or further dissection, worsening dissection. So you want to lower that BP as fast as possible. Like you want to really push your beta blocker immediately because your target systolic is less than 120. And also in terms of your heart rate, because if your heart is beating fast, it's still pushing a lot of volume immediately, and that will also widen your dissection, okay? So yeah, the agents that we want, esmolol is a good one. If you don't have that, so esmolol plus now the nitroglycerin or nitroprusside. If you have nicardipine, wonderful. You can also use labetalol if that's what is available, okay? If you're thinking that there's like a regurgitant, valvular regurgitation, you might want to avoid the beta blockers because it'll just worsen, or if you have a tamponade, okay? All right, so that's for your heart-lung complex, okay? For your kidneys, again, damage has been happening for a while, so you have a bit more leeway in terms of time. You want to lower your BPs gradually over time. And this one, the target is based on the mean arterial pressures. So you want to lower by 20-25% over a couple of hours. The drugs here are your labetalol, works really well there. Okay, then your, in terms of CNS, your brain, the targets are slightly different based on what you're planning to do for your patient. If it's an ischemic stroke and you want to thrombolize, you want your blood pressures to be lowered within the first hour. And the number that we're looking at, your maps need to go back down by 15%. So you want your pre-thrombolysis BPs, systolic need to be less than 185, 110. So remember that was the relative contraindication. If it's above these numbers, it's a relative contraindication. So you lower it, and then you can thrombolize as appropriate, okay? But if you're not thrombolizing, you want to lower it a bit slower, maybe even up to 24 hours, where you want your systolics less than 180 still, okay? But yeah, it's a more gradual lowering. Drug of choice that is often available is labetalol. but you can also use nicardipine. But yeah, labetalol is good for you. And labetalol carries across all neurological hypertensive emergencies. Okay, so if it's a bleed, again, depends on whether it's a subarachnoid or an intracranial. Subarachnoid, you want to lower very fast immediately. And your range should be between 130 to 150. If it's a intracerebral, you lower it, yes, but you take a bit more time because you don't want to risk reflex hypoperfusion, okay? So again, like I said, labetalol is your drug of choice. And then for your patient who you've scanned and you've ruled out any other possible cause of the encephalopathy, you've scanned, you've done your LFTs, all those things, and you think it's now only a hypertensive encephalopathy, you want to reduce your BP immediately, like very, very fast, targeting a MAP reduction in your MAPs by 20 to 25%. So again, everything is just based on what your initial blood pressure reading is, and then you have to calculate back downwards to see what target you want to get to, okay? Again, labetalol is your friend, okay? If nicardipine is available, you can also use that, okay? For our pregnant patients, I think pregnancy-related emergencies are very well, are highly invested in. So it would be rare to find someone who is unaware of how we manage eclampsia, preeclampsia. So yep, you want immediate BP reduction. Your systolic should be less than 160, diastolic less than 105. We use labetalol, and then you also give magnesium sulfate for neuroprotection. Okay, so that's a brief chart overview, which is just a charted version of what this is, okay? The only other thing is now in terms of your secondary hypertensive emergencies, your cocaine of your chromocytomas. So it's not often that you have to give an antihypertensive, but when you find that you must, the drugs that you use are different than the other ones. So these are the ones who you'd give your diazepam, phentolamine for, especially for your chromocytomas, but you can also use nitroglycerin and nitroprusside, okay? All right. Yeah, so we also, because it's your alpha adrenergic is just haywire, so that's why the drugs change, and it's not beta blockers, because if you give a beta blocker, you'll just be encouraging the alpha adrenergic activity to continue happening, okay? All right. Okay, let me take a breath there. Okay, so again, we go back to this slide. Management of hypertensive emergencies, once you've already confirmed that there is an emergency, it's immediate, number one. Number two, it's IV, not oral. Number three, medication is based on what the patient has, what is available, and then also must also consider your ABCDs, okay? Yeah. So for the patients who, now we've understood what we're supposed to do. So we can go back to our first patient of the webinar. I will not give him a name, Mr. M. Mill, 52-year-old, known hypertensive. He's walked into the hospital with a bit of a headache. Says he's not taken his medication for a while because he felt better. Initial BPs were 182 over 109. Okay, so the next appropriate step, like most of you said, is you take your history, you do your examination, you can repeat your BP after that. You do your, in terms of your history, you're looking for red flags that could mean that there's some form of end organ damage, okay? If none of the questions elicit anything, you proceed to your ECG and your labs. How does your ECG look like? Is it normal? Is it abnormal? Are there signs of ACS? Are there signs of heart failure? In terms of your labs, your imaging, if they have a headache alone doesn't mean anything, honestly, because I think we've all had people say, oh, nilijua pressure iko juu nilikuwa na headache, right? So headache alone doesn't mean it's an emergency. Headache plus other things, and then prompting you to image, and then positive imaging findings or suggestive imaging findings, because like with MRI and TA, it's going to be negative. That would lead you to think there's an emergency, okay? So you do your tests, you do your scans as appropriate, and then you see from there, okay? So please note again, just because he come in with high BPs doesn't mean I give him a sublingual medication, okay? Amlodipine, nifedipine, hydralazine, nor does it mean that you push an IV antihypertensive medication like labetalol or hydralazine, okay? You'll be doing more damage than good for your patient, especially if it's like this guy who only needs to just restart his medication, okay? So again, take your history. Are there any neurological symptoms or signs? If yes, scan as appropriate. If no, and you continue with your history, are there any signs of cardiac or cardiopulmonary issues? Is there chest pain? Is there shortness of breath? Is there what's it called? Features of fluid overload state? Okay, your palm edema, your peripheral edema. Yes or no? If no, are they having any urine retention? Okay, are they in a fluid overload state? Your CKD patient, have their creatinine suddenly gotten worse? Okay, then in terms of their eyes, are they seeing okay? Do they usually wear glasses? If they usually wear glasses, has their vision changed from their normal baseline? Okay, so those are some of the questions you need to ask. Once you've asked and you elicit a yes, you investigate as appropriate for each organ system that you're worried about. If you investigate that and you find that there is organ damage, acute organ damage that can only be attributed to the sudden rise in high blood pressure, that is a hypertensive emergency, and you need immediate management, okay? If you go through that whole algorithm, all your answers are no. You've evaluated, you've investigated as appropriate, everything looks normal or acceptable. Discharge with oral medication, advice on lifestyle modification, and a follow-up plan in the clinic, okay? After you've done your risk stratification. Some patients also need like statins and things like that. So that's all part of your labs. So that's the approach that we want you to have. So again, if there's a hypertensive emergency that's confirmed, stabilize your patient while they're in the unit. A patient who is in the emergency department is your responsibility until they leave, okay? So stabilize your patient and then admit them to a critical care unit as appropriate. If you must transfer, make sure, again, they're stable prior to transfer. You don't want somebody to arrest in an ambulance. Okay, and also these are the patients who ACLS ambulances. Okay, and ambulances are a topic for another day. So if you've gone down your algorithm and everything looks good and dandy, and it's just this lovely Mr. M, 52-year-old, who's just tired of taking medication and felt better, you need to do appropriate counseling. Tell him, okay, hypertension is a lifestyle, long life illness. You need to continue managing it forever in terms of your lifestyle. You need to keep taking your medication. Everything is okay. I understand, yes, your BPs are high now, but it's because we've not taken our medication. Once you take your medication, they'll come back to normal, but that doesn't mean you stop taking it. You continue taking your medication and continue being followed up, okay? So yeah. So we've managed Mr. appropriately, okay? All right, now let me look at the chat. It has been buzzing with questions. I hope we're all clear, okay? So it's either you have a hypertensive emergency or you have a symptomatic elevated blood pressure, okay? Yes, we're not saying you don't do anything for the ones who don't have emergencies, but it means you don't panic and you reassure them as well. Okay. Okay. Mhm. Okay. Mhm. Okay. Any questions so far? I hope we're all clear on how we approach basically hypertensive patients and hypertensive emergencies. Because again, like we said at the start, hypertensive emergencies, hypertension in general are a very common presentation to the emergency department, but hypertensive emergencies are what will keep you there and make me want to jump and lower your BP, okay? All right. So in the Q&A, Jimmy asks, is it advisable to discharge a patient with BPs above 180, 110 after confirming there's no evidence of target organ damage on oral meds? Yes, so that's exactly what we're saying, okay? A single BP reading alone that is high should not make you panic, okay? And it doesn't equate hypertensive emergencies. As long as you've worked them up and you've ruled out and documented very clearly that there's no target organ damage, you need to now do the second prong. Counsel your patient, start them on medication, enforce the need to continue and be compliant with the medication, tell them about lifestyle measures, especially in terms of, I think one of the biggest cardiovascular risk factors, especially hypertensive emergencies, is linked to sodium intake. So they need a holistic approach, right? But the conversation starts with you in the emergency department. You tell them you need to take these dawahs, you need to adjust your lifestyle, you need to adjust your diet, your exercise levels, and then you need follow-up in the clinic as you take your medicines. And then where possible, please discharge them with the BP machine so that they can also take their pressures at home. Okay? All right. So reference is the 2024 European Society of Cardiology updates in management, guidelines in management of hypertension and hypertensive emergencies, similar to also the AHA guidelines. It is also in our EMKF guidelines as well. Yeah. Okay. So someone asks, can Lasix be used to lower BP in hypertensive emergencies? So Lasix, we're not using it to lower the BPs, we're using it to reduce the fluid overload state in acute cardiogenic pulmonedema. Yeah, that's the thing. So you will still need a BP lowering agent, whether it's like your nitroglycerins and things like that in conjunction, or your but in conjunction with the Lasix. It cannot be used alone. Okay. Okay. So someone asks, what dose should we use for labetalol or hydralazine? So they're all in the EMKF guidelines. For adults, a maximum of 20 milligrams of labetalol is used. And then you can titrate as needed because labetalol wears off very fast, okay? The first dose you give will last for like 30 minutes at most, okay? For hydralazine, usually you give 10. You start with 10, maximum of 20 as a slow push, and then you can repeat QID if needed. Then yeah, what would be the appropriate step of managing for such a patient if he presented in a peripheral facility before referring to a peripheral facility? So if you're in a peripheral facility, do all the investigations that you deem necessary based on your patient's complaints and physical exam findings, okay? Do the ones that you have available. Then whatever you don't have, you can also refer for that with a stable patient. Yes. Here, someone asked, how do you approach hypertensive emergencies with high unrecordable sugars as well? So again, like, yeah, RBS is part of our first thing that we do. If it's unrecordably high, and you're thinking also there's ketosis, manage as per your hypertensive emergency and DKA protocol together, because yes, patients can have more than one thing at the same time. Okay. Let me see. So in rural centers where there are no IV drugs, uh, what should the approach be? Now, again, this is me teaching best practice based on what we should all have. I think in terms of emergency care, emergency drug lists, hydralazine, labetalol are there. They should be available. I know it's not always the situation called ground. It's not always the truth, but again, this is kind of part of what AMKF is doing, but also you can do in terms of advocacy for all these patients, especially Kwanza hydralazine, labetalol in conjunction with maternal emergencies. That's a big one that's almost always there. So should be able to be used. If you can't find it, your ED, check maternity because they possibly have it. Okay. Okay, someone wants me to clarify again. Asymptomatic high blood pressure for non-compliant patients. You talk to them and tell them, excuse me, sir, you need to take your medicines. Do you want to die? Okay, because you can die. Hypertension is a silent killer. Please take your medicines. Please exercise. Please adjust your diet. Please come to clinic for follow-up. That is how you adjust. That is how you approach that patient. Okay, and then you tell them, yes, I know you're feeling better, but it's because you took the dawas. Okay, yeah. Mhm, 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 mhm. So some patients might not afford CT scan straight away. They'll probably have high BPs, low GCS. Do we still lower the blood pressure? Again, these are the teething problems of our failing healthcare system. Sorry, my views are my own. You do what you can, honestly. Because if you have a low GCS and you don't have any imaging, you can try and rely on your clinical acumen or your clinical exam, because sometimes things as subtle as eliciting pain can make you see that there's a left-sided weakness and you think there's a stroke. Okay. Things like looking at the pupils, you can see anisocoria, thinking that you might have a bleed. Okay. So the less facilities we have, the heavier we rely on our clinical acumen in our clinical exam, so that you can try and make as close a diagnosis as possible without those resources. I think it's even what we've all been taught. History and physical exam should give you 90% of what your diagnosis you think it is. So if there's a low GCS, again, remember your ABCs. If they need to be intubated, intubate them. Stabilize as much as possible. Based on neurological, most targets are the same. You can lower them a little bit, but refer for proper full management thereafter. Okay. Someone asked, do we lower BPs with orals or IV meds for asymptomatic? Okay, let's start again from the beginning. So when your patient comes in and they have high BPs, evaluate for hypertensive emergencies, which are end organ damage. Okay. If there is signs of that, give your IVs to lower immediately. If there is no signs of that, maybe they're just asymptomatic and they only have high BPs, discharge on orals. Okay. Do not lower with oral medications in the emergency department. There's nothing you're doing there. Okay. If it's an emergency, IVs. And emergencies are only documented by labs imaging. Okay. Right. Okay, guys. Mhm. Mhm. So In terms of managing hypertension alone, again, that was not really the scope, but even in our algorithms for your asymptomatic high BP patients, there's a guideline on which drugs you need to start with for especially our African population. And it's usually a combination because, again, for our race, there are also nuances in terms of the drugs that will actually work for us and which ones won't. So let's refer to our algorithms and then we see. Josh asks, when should I consider transitioning from IV to orals? Okay, that's a very good question. So number one, like we said, target BP readings is one thing, and then resolution of symptoms, and when your BP starts to come down and improvement in your patient's clinical status will prompt you to transition to orals. Okay, all right. What can you advise about herbal drugs for hypertensive treatment? There's nothing like that. Herbal drugs do not treat hypertension. Herbal drugs, the problem with herbal drugs is there's no way to know in terms of potency, dosing, all those things, okay? So herbal drugs can be not even supplements or good balanced diet can be used in terms of lifestyle modification for all of our patients, but there is no role for herbal drugs in managing hypertension. Thank you. Okay. Okay, there's a question about for a patient who has a stroke and now has seizures, do we lower the blood pressure first or do we address the convulsions first? I'm going to give a very political answer. You can do both at the same time because, again, we manage emergencies as a team, okay? But you also need to ask yourself, what is causing the seizures? Is the seizures because of, I don't know, herniation, mass effect, things like that? Or is it because of a new thing, right? But depending, and then also what are the events surrounding patient to be brought to the hospital, okay? So if you're thinking they're having seizures or a stroke or they've taken drugs, maybe you might think benzodiazepines are a better option first, and then, but again, address the one that is most addressed as a team. So you can't give two drugs at the same time, and then address the one that's gonna kill them first. Yeah. Okay. Okay. All right, guys, I think our time is almost up. More questions can also be put in our EMKF WhatsApp platform, and I will answer each of them as we go along, especially the ones that have not answered here. But a lot of the information that I've actually just presented is in our algorithms. So feel free to look through our algorithms again. The Casualty app is a very good resource, especially even for me, I refer to it every day in my clinical practice. So let's keep looking at that. Let's remember what our emergencies are, where we have the systolic blood pressure above 180/120 with acute hypertension mediated organ damage, okay? And it is not a stable patient who has refused to take his meds. And let us also remember there's nothing like a hypertensive emergency anymore, okay? It's either an emergency or an asymptomatic high BP reading. Let's evaluate for organ damage. If there is none, multidisciplinary approach for your patient as outpatient. Okay, all right. Thank you so much, everybody, for joining. It's been an awesome session, all 210 of you. I'm very, very grateful for everyone. I hope this helps you be better medical practitioners for your patients so that even when you need the care, you're in safe hands. Thank you.